Okay, well, hi. Welcome to today's webinar. My name is Tiffany Fennell, and I'm the chair of the Division 18 VA section. And I'd like to welcome you to today's webinar on working with race-based stress and trauma. This webinar is part of the Starting the Conversation series, which is a collaboration between APA Division 18 Veterans Affairs section and AVAPAL's Psychologists of Color Special Interest Group. And we've had other topics in the series, and we'll continue to offer more programming around diversity topics just to help continue the conversation. And I also want to thank everyone for making the time to join us today. We know that these are really important dialogues to have, and taking the time and showing that it's important has really meant a lot to us. A couple of housekeeping things I want to bring up are CE credit. So today's webinar is 1.5 hours long, and so you will be able to record 1.5 hours of CE credit. So I'll talk more about how to do that at the end of today's webinar. And the other bit of housekeeping is that the panelists and the presenters welcome your questions, and you can use the Q&A box to ask those questions. We'll be fielding them and responding to them during the panelist discussion. And so I'm going to introduce the moderator today and presenters, and we do have several other panelists, and they'll be introduced later. But first, our moderator today is Dr. Veronica Shead. She's a staff psychologist in palliative care at the VA St. Louis Healthcare System, and she serves on AVAPAL Psychologists of Color SIG leadership team. And we have two presenters. The first is Dr. Asale Hubbard. She's a staff psychologist and integrative behavioral health director at the San Francisco VA. And she also serves on the AVAPAL Psychologists of Color SIG leadership team. And Dr. Marva Robinson is a staff psychologist in primary care mental health integration at the North County CBOC within the St. Louis VA and Midwestern Regional representative for the Association of Black Psychologists. So without further ado, I'm going to mic over to Dr. Asale Hubbard.
Thank you so much, Tiffany. And please let me know if for any reason anyone can't hear me. I'm going to go ahead and get us started today with our presentation. And we'll ask, naturally, you might have some questions as part of the presentation. And we're going to try to address any questions that you might have during our time towards the end of our panel. So look forward to speaking with you all a little bit later. Give me just a second here to bring up the presentation. So as was stated, we're going to be talking specifically today about working with race-based stress and trauma. And we're really glad and happy to see so many people here and interested in this topic. And so one of the things that we thought was really important before we kind of talk about more broad questions in terms of what this looks like clinically and particular questions that you may have, is we wanted to spend a little bit of time laying down the foundation and the groundwork, if you will, related to what we mean when we talk about race-based stress or trauma or just racial trauma in general, and give you some vocabulary and things to think about related to this topic. We don't have any disclosures to name as part of this presentation. So for me, one of the things that's always really important that we name and acknowledge is the why of this topic. So why are we talking about this? Why is this important and relevant for us? And so want to really name that. Many people may already be aware, but it's really important to name the fact that experiences such as racism or discrimination can have numerous impacts on people in terms of their physical as well as mental and emotional well-being. And so it's really important that we name that, because that's going to be, you know, part of what we're seeing in terms of the clinical picture, in terms of who we're working with. So people experiencing things such as depression, stress, or anxiety related to these types of experiences, as well as chronic health conditions, coronary artery disease, hypertension, and even early deaths as a as it relates to a accumulation of experiences over time. So the more experiences that individuals have over time, this leads to, greater negative health outcomes for many individuals. And as we know, there can be a lot of nuances in terms of individuals' ability to cope with any number of stressors, and this is no different. And so that also can play a major role in terms of outcomes. Now, I want to talk a little bit specifically about the veteran population, as we are VA providers, and a little bit about what the research says related to veterans specifically. And so one of the things that we know is that for OEF, OIF veterans, as well as our Vietnam veterans, they report higher rates of PTSD, exposure to race-based type stressors, has been found to be actually a predictor of PTSD. And so these are two groups in general that have reported higher rates. This is really important for a number of reasons, but one of the things that's really important in terms of our work is that oftentimes many providers may not think to actually assess this in the work that they're doing with their patients. And so it's really important for us to know that this is happening. And understandably, many patients may not be willing to volunteer this information to us in terms of that these are experiences that they've had. And it's for reasons why people may not disclose for other concerns. So things, fear, worried about, am I going to be safe to share this? Is this even something that someone's going to believe? And is it even worthy of treatment? People may feel like I'm only able to talk about, combat stress or maybe military sexual trauma, but this trauma doesn't kind of meet that category and maybe isn't worthy of me bringing up to my provider. One other thing that I want to note here too, some other research that I don't have on this slide, but I also think is important to name that I was just thinking about is when it comes to primary care mental health, some of the research has also talked about people of color indicating that they're having a lot poorer experiences in primary care mental health. And this is really important for us to know because as we know, in the VA system, that's kind of the first entry point for many veterans in terms of getting connected. And so if people at that point aren't having positive experiences, understandably, that's going to have some impacts for that individual in terms of what that means related to whether or not they'll continue on with any mental health care at all. In addition, when it comes to compensation and pensions examinations, Black veterans in particular are less likely to receive diagnoses of PTSD and less likely to receive service connection for PTSD, which is very important. A couple other anecdotes just from things that we've heard clinically from patients, particularly Vietnam veterans that identify as Asian American, being told statements as, this is what the enemy looks like, having someone kind of point to them and say that so that other people know what to look at. And that being something that was very impactful for people. People talking about being kind of left out to die because of their race or experiencing all different forms and types of harassments. So these are things that, for racial and ethnic minority veterans is something that's really important. And although we're talking about race, I also don't want to leave out the point that the intersectionality of identities and how that's important and nuanced in terms of what people's experiences might be. And lastly, just the sense of institutional betrayal that many people feel in the sense that I'm out here to fight alongside and don't feel like I can really trust the people that are next to me. We want to kind of shift to talk a little bit about theoretically and conceptually, what do we do with this information? And so I want to discuss one particular theory that's been put out there by Robert Carter that talks about race-based traumatic stress and defines it as being the psychological as well as physiological outcomes of racist incidences. And these can be of a wide variety, such as discrimination, harassment, discriminatory harassment. And so we're going to spend a little bit of time talking a little bit more about this particular model. So when we talk about race-based traumatic stress, it can be defined in a multitude of different ways. And so this slide really kind of highlights some of the ways that it can be defined as a type of emotional injury motivated by fear or hate of another person or group of people as a result of their race. It can overwhelm someone's ability to cope. It can be related to bodily harm or threaten one's life integrity. And it can also be something that's happening in a multitude of different ways, be it interpersonal, institutional, societal, that can cause things in the individual such as fear, helplessness, or horror. And one of the things that's really important as we talk about this, you're probably already starting to notice some nuances or similarities to this. This that we're defining here is not something that's recognized, as a DSM-5 disorder. And there's a lot of talk in the literature about, what that means. And Carter's, Dr. Carter's stance on this is really that this is really something that's distinct, even if there are areas and ways that it might seem similar to other diagnoses that we are very familiar with. One of the things that I wanted to take some time for us to look at that I think is really important, and this is something I will say for myself clinically, I use often with patients when I'm talking about experiences of race-based stress and trauma. It really helps them to build some insight and awareness to what is happening to them, the why it's happening to them, and really puts together a picture for them that helps them to really build understanding of their reactions to different things that they're experiencing. And so I think this is kind of a nice chart that really kind of summarizes the theory. And so Dr. Carter really calls this race-based traumatic stress injury, and really kind of takes us through when we talk about these experiences. As I said before, this can happen in a multitude of different ways. It can be on an individual level, institutional, cultural level, and manifest in a number of different forms, whether it's exclusion of individuals, whether it's physical, verbal, interpersonal assaults, whether it's feeling isolation at work, denial of promotion. So there's really a multitude of different ways that this can be experienced by an individual. But one of the things that they all have in common is that it can cause negative emotions. These things can be sudden and often uncontrollable, and lead to a cluster of symptoms that we're familiar with, such as avoidance, intrusion, arousal, leading to a number of symptoms. Ones that we may have talked about and heard frequently in trauma literature, such as flashbacks, nightmares, depression, poor relationships. Something else that I think that's interesting that Dr. Carter talks about, though, is there can be other outcomes that people experience, such as an increased awareness or participation in one's spiritual or religious orientation, engagement in activism, as well as this idea or commitment to being strong. We've talked a lot about the idea of trauma and PTSD and what that can look like, and wanted to kind of talk about in some of the ways that this construct kind of maps onto other constructs that we're familiar with. Starting with those re-experiencing symptoms, the flashbacks, the intrusive thoughts, heightened arousal. So this heightened cultural mistrust, distancing from loved ones, negative emotions, cognitions, mood, shift in one's racial identity, and an increase in somatic complaints. And then avoidance, denial, or treating or naming the experience as being something other than racism, unwilling to see it as racism or discrimination. So these are some of the ways that this can manifest in some of those different symptom clusters that we often talk about when we talk about trauma or PTSD specifically. So I've already mentioned to you that this construct, this concept is not one that's included in the DSM-5. And when we talk about PTSD and questions about, is this PTSD or is this something distinct? you know, one of the things that is really important is that a lot of experiences, microaggressions, institutional discrimination, would not meet what we would historically name and call a criterion A event. And so it's really important for us to understand that we might miss these experiences just by way of our kind of programming that tells us only to look for things that would be considered criterion A type events. The other thing that we know is that these experiences and the level of threat or danger that one may have is really a moving target. So when we talk about safety, that can look different in terms of context and may change in terms of form, whether things are more overt in nature, like overt acts of hate, versus things are more microaggressions that people are kind of wondering kind of what happened in that situation when they said that to me. And of course, things like vicarious trauma, as we're aware of in terms of media images and things that can have an impact. And we know quite recently over time, but especially more recently, this is something that's happening quite frequently. So next question, naturally, that people want to know about is, well, how do we assess for these types of experiences? And one of the things that can be kind of challenging about this is that it can be difficult to obtain as accurate an assessment as we would like using our traditional methods. So if you think about having to ask or capture criterion A trauma, and I just told you that a lot of these experiences don't fall into that, well, your standard caps might potentially doing that or and using another measure might potentially miss some of these experiences. And again, because it can happen in many different forms. And one of the things that's really important is we're really often talking about experiences that are taking place over a long time period, not singular events. Although, you know, one of the things that Carter talks about, if you remember the slide where I showed you that diagram, one of the things that's really important for us to name is that there's this idea that he describes as kind of the last straw phenomenon. And what that means is that an individual may have a number of experiences over time, maybe more overt, maybe more covert microaggressions, and they may find ways to cope with those experiences. Healthy or otherwise. But the idea is that there might be an event that comes along, and it might even be something that under other circumstances, the person potentially might not even have that strong of a reaction to, but in that instance, it does cause a reaction. And it's kind of like the last straw, as he says, and that can kind of lead a person to potentially experience a number of changes that can have an impact on their health and well-being. And so that's really important to note. Now, there are measures out there that kind of tap into experiences of racism and discrimination, and I've named some of them here. Most familiar with the race-based traumatic symptom scale. That is one developed by Dr. Carter, and we'd actually tried to use this clinically. And one of the things that can be one of the limitations of some of these measures is that they are excellent measures, and clinical utility sometimes is not always quite ideal, as this particular measure was one that was quite lengthy for veterans to fill out. And so we deemed it not as clinically useful in the ways that we were hoping to use it as part of our group. And we'll talk a little bit more about the group a bit later. Last thing that I really want to say before I'm going to shift here to my colleague who's going to talk a little bit more about treatment is there has been a couple recent updates in assessment that's really important to talk about, and I have included two here. It's the Trauma Symptoms of Discrimination Scale and a scale called UNREST, the Yukon Racial Ethnic Stress and Trauma Survey. This first one, the discrimination scale, it's not looking solely at experiences of racism. It's looking at experiences more broadly based on different identities that people might hold. But it is a brief measure, about 21 questions, and it does give you some insight into the experience of discriminations people may experience based on their race, ethnicity, gender, sexual orientation, and so on. The unrest measure is one that's very similar actually in structure to the CAPS, giving someone the CAPS and alter some of the questions that we might use in the CAPS to really focus on experiences related to racism and discrimination. And towards the end of the assessment, it even includes some information for you to understand potentially how you might think of the experience or experiences that the individual named using that kind of criterion A kind of language that we're accustomed to. This is, like the CAPS, a longer assessment. Estimated time to complete this would be about 45 minutes. So again, it's going to vary in terms of its kind of clinical utility in terms of who or how might use this. Despite this, one of the things that we've done at the San Francisco VA, I took one of the questions from the unrest and kind of adapted it as kind of a one question, two-part question that we've embedded in one of our clinics. We call our post 9/11 or the OEF clinic, and to pilot it, and we've really been able to see kind of how it's kind of changed the conversation, and now we're trying to adapt it more widely across our mental health service. So with that, I'm going to pause and allow my colleague to come on in and talk a little bit about treatment.
Thank you. Okay, so to invite a patient into your office, especially a veteran of color, and not ask about, acknowledge, or give the slightest interest in their full service experience is to do a disservice. Research shows higher treatment dropout rates among ethnic minority veterans suggest we may not be fulfilling our mission to serve minority veterans in the fullest way possible. And Asale did do a great job of expressing and highlighting some of those studies, and a couple have been dropped into the link chat boxes. We must, as ethical clinicians, find a way to reach all veterans we serve. And I think we can all agree that in order to take a journey with a vet from point A to point B, we must at some point address unique cultural differences. Agreed? Next slide. So we have found that that's not quite what's happening on a larger scale. What we have seen in research confirms is that despite the need to address racism and ethno-violence in treatment, we could not find any treatment studies examining the effects of trauma-focused therapy for race-based trauma. A quote from Helms and Associates from their 2010 publication states, "Virtually missing from contemporary trauma literature is the consideration of racism and ethno-violence as a catalyst for PTSD and related symptoms." Most randomized controlled trials examining treatment protocols like prolonged exposure and cognitive processing therapy study predominantly white patients and do not explicitly address race-based trauma. I love this illustration that we have up here above because it shows if we decide to focus on equality by applying the same evidence-based treatment protocol to every vet who walks in, you will still have vets, especially those of color, who will be left out of the opportunity to have symptom relief. However, if your goal isn't just to equally apply the same treatment approach to everyone, but for everyone to experience life at its fullest, free of symptoms and suffering, then your focus is on how to adapt your protocol to get the individual patient to where they need to be. Next slide, thank you. So how do we do that, right? How do we adapt what's given and make it sufficient for all to achieve the same goal? We recommend adapting existing treatment to be more culturally informed and also offering group treatment which specifically targets race-based stress and trauma. First, in looking at how to adapt individual treatment, we offer three suggestions. One, understand the historical and societal context of racism and intentionally explore its impact on your patient. You've got to be able and be comfortable with asking some of those tough questions. Your standard intake should include things like, did you experience any racism or discrimination while you were in service? 2, make the space to build rapport and to engage, literally. This will require allowing additional time for that relationship to foster. By extending your session time or extending the number of sessions you would typically allow for rapport building, or extending your expectations of what you expect a protocol to be completed within. Because remember, you will have these intimate conversations along the way as you explore their unique experiences. And 3, a very important part of the adaptation is to affirm, empower, and support. This will require you to be familiar with techniques, homework, and other adaptive interventions, which affirm cultural strengths, which lead to empowerment and increased self-esteem. I can share more examples of this empowerment piece as we get into the group format that we use. So now that we've shared a few tips of how to adapt standard individual protocols, we will briefly share information about the race-based stress and trauma empowerment groups that we currently run. So the race-based stress and trauma empowerment groups we run today are informed by the race-based stress and trauma and resiliency group protocol that was developed by Drs. Marie Carlson and Maurice Endsley, who you'll get to hear from later today, in collaboration at the Central Texas VA Healthcare System. It's an 8-session protocol geared for members to meet for 90 minutes per session. Groups meet typically once a week and have been proven to be just as effective virtually, given if you're able to manage a chat box and play video clips and be a presenter all at once. But we've been able to adapt just fine with also offering these same groups virtually, given that we're in the current pandemic. The protocol includes evidence-based elements such as psychoeducation, mindfulness, and relaxation practices, CBT techniques, and empowerment approaches. The overarching goals for the group treatment is to provide a safe environment for veterans, reduce internalization of negative messages, improve coping mechanisms, while also empowering positive action. Next slide. So each session covers different topics. Earlier in this presentation, I explained how extended time is needed to build rapport and to create a psychologically safe space. We dedicate our entire first session, 90 minutes, to doing just that. And it's an ongoing part of each of the subsequent 7 sessions. As you can see from the list of topics, we cover a wide range of things. In session 2, we spend over an hour breaking down helpful and harmful ways of addressing race, while also teaching our veterans some of the barriers which may come up for people in discussing this topic. We provide psychoeducation about microaggressions in session 3, and also cover the physiological reactions to race-based stress and trauma in session 7. Next slide. So each of the 8 sessions follow the same format, in that we open with reviewing the session agenda. From there, we go over the day's discussion topic. We then move into a relaxation or a mindfulness exercise to center the group participants, and that can be anything from guided imagery to progressive muscle relaxation. We then review the homework they completed from the previous week. Typically, their journal entries in addition to other homework assignments that were given. We then spend the bulk of our time, about a good hour, in the discussion topic for that particular day. There we do a lot of back and forth, a lot of feedback, a lot of challenging, and also raising some awareness. And then we wrap up with closing questions, comments, and feedback. And we always close with homework assignments as well as an empowerment exercise for that day. Next slide. One of the key elements and what our vets have really done a beautiful job in making their own is the empowerment piece of the group. This is where we challenge them to take what they know, what we've shared with them, and to do something with that energy. The empowerment exercise changes with each session, but largely consists of visiting a historical site or writing letters to local and national politicians, and also group work like engaging in peaceful protests. We encourage them to pick an activity that positively affirms the culture of racial ethnic minorities or advocates for the rights of racial ethnic minorities or some other minority population. This piece of our work has led to veterans not only being active in raising their voices, but it's led some of them to create their own organizations. Some have formed groups and social media presence. I've had vets to create hashtags that have gone. We have some vets that meet in each other's homes to plan their next actions, and others that have been inspired to just start their own grassroots work. You will have an opportunity to speak to the other amazing facilitators of this work, but I think I can speak for all of us when I say we have learned just as much from our veterans as they have learned from us. So thank you for sitting with us through this brief educational speech, and I will turn it over to our moderator for the panel discussion.
Hello, everyone. Can you hear me? I just want to say thank you so much to Drs. Hubbard and Robinson for their presentation. I think it truly sets us up to have a wonderful discussion with the esteemed panelists that we have today. And I can say that because I work well with all of the panelists. They are not only doing excellent clinical work, but that just genuinely are excellent psychologists overall and people that you all should know. So to start that off again, I'm Veronica Shead, and our first panelist is Sam Wan. Sam is the Director of Clinical Training for the Postdoctoral Fellowship Training Program. He's a staff psychologist and a clinical supervisor with the Substance Use and PTSD Clinic at the San Francisco VA Healthcare System. So that's Sam. Say hello, Sam, so that I think your picture will show up for them.
Hello.
Next, we have Dr. Maurice Endsley. He is a staff psychologist in primary care behavioral health at the Edwards Hines Jr. VA Hospital. And he is co-lead for a VA innovation project that has supported the spread of the race-based stress and trauma group-based intervention to support veterans of color. So again, we are working to get this, if you are interested in a group, we are working to get that out there. And this panel has been working very hard to disseminate this information. Next, we have Dr. Claire, Maurice, say hello so that you're—
Hello.
Clarice Wang is, Dr. Clarice Wang is a staff psychologist at the VA San Diego Healthcare System and co-leads a multi-site project examining outcomes for a race-based stress and trauma group for veterans of color. So say hello.
Hi, everyone.
Clarice as well. And next we have Dr. Keisha Ross. She is a staff psychologist at St. Louis VA at the John Cochran Division in the Mental Health Clinic. She is co-leader of the Innovation Race-Based Stress and Trauma Grant and serves as a project manager of the Race-Based Stress and Trauma National Consultant Group. She also serves as co-chair of the St. Louis VA Psychology Cultural Competency Committee. Her leadership roles include past president of the Missouri Psychological Association and founding committee chairperson of MOPA's Diversity Committee. And then we also have, sorry, I'm looking at multiple screens at once. Then we also have Juliette McClendon. And Dr. McClendon is a staff psychologist in the National Center for PTSD Women's Health Sciences Division at VA Boston and funded by a VA Career Development Award to evaluate the race-based stress and trauma group intervention with veterans of color. She is also an assistant professor of psychiatry at Boston University School of Medicine. So say hello as well.
Hi, everyone.
All right. So as you see, we have an esteemed panel of guests today, I should say, of specialists, because of the work that's been done over the past few years as a group. And so if we could get started, I think we've heard a great deal of information surrounding the background of race-based stress and trauma. But I think one of the big questions is, how do you discuss this with your veterans? So Maurice, how would you define race-based stress and trauma to your patients?
Yeah, that's a great question. I would say that it is a tough one to sometimes describe, because many of them are everyday things that they experience. So when I talk about race-based stress and trauma, I oftentimes focus on those different experiences that lead them to kind of notice, I think specifically, how they're treated in society, kind of the impact that it has on them. So these oftentimes I use examples like witnessing, violence against people who they sort of identify with racially or ethnically. So having to witness that, seeing the news reports, seeing how the media presents them, getting these sort of, slights, microaggressions. So I oftentimes use a lot of sets of examples of what these look like, including microaggressions, and different examples. I oftentimes have a slide that I oftentimes do share that also will kind of walk through the different definitions that people have for this, unfortunately, because we don't quite have a diagnosis per se, but that's typically how I kind of walk patients through how to kind of understand the concept of what this is.
So I think a good follow-up question to that is so when we're describing something to someone, I think the other thing is that what are they seeing within themselves? So Keisha, what would you say, how does race-based stress and trauma manifest in patients? What are some of the things that they might be noticing for themselves?
Well, Dr. Hubbard, she gave a great background just in terms of like Carter's model, but I can talk a little bit just in terms of like doing the group, how it actually feels and manifests what veterans actually talk about. So when we talk about intrusions, flashbacks, avoidance, for some veterans, that's in the form of what they experienced during their military time. We have some who are having challenges still due to being in dangerous situations because they were left out without any backup due to their race. So we have individuals that still have significant flashbacks about that, nightmares. We also see that increased arousal piece, that irritability. And with all that's going on in our social climate, and with the media, it's much different today because, the television can broadcast, very traumatic instances of racial killings or brutality. So we have a lot of conversations in group that is also related to just that fear, that hyperarousal, even driving in their cars, leaving their homes. If they own businesses, there's concern about, safety within those areas, because sometimes they're challenged, is this your home? Is this your business? Is this your car? So, the discrimination is just manifested in different ways. We have those who also talk about discomfort of being in predominantly white environments. So the level of stress that they experience on their jobs or sometimes in their communities, depending on where they live. Right now, there are many veterans that there's so much hyperarousal just in terms of their neighborhoods and safety. So even just leaving their home, there is concern about safety. So that's a big part of it. There's also, as we talked about, depression for some, anxiety. Sometimes there's shame and guilt that's tied into, their racial or cultural identity. That's why this group is so powerful, because a big part of empowerment is also focusing on how do you build and maintain a healthy racial and cultural sense of self in the midst of racism.
Thank you. So building upon that, a lot of people are asking about how to set up and participate. How would they institute or have one of these groups? For those of you who are interested, we do offer consultation for this group. And we'll be able, through that consultation process, to also allow you and give you information about the protocol and walk you through everything from recruitment to implementation of those groups. So if people are interested in that, we can also get you kind of filtered into those consultation calls as well. But building upon that, I think people are looking at the composition of those groups and what that might look like. So, so one of the things and one of the questions that a lot of people have asked, and for our group, the majority of these groups have been led by by clinicians of color. So Clarice, as a clinician of color, do you self-disclose during the group? And if so, how do you maintain those boundaries? So what is that like, you know, what is that group setting like for you?
Yeah, absolutely. I think that in these groups in particular, and also if you're working individually with veterans of color who have experienced race-based trauma, self-disclosure is an important component of the treatment, and I think a unique component in that sense for a couple different reasons. One, you know, as we've discussed in our excellent presentations, it is incredibly important to take the time to build that rapport, to address some of these historically rooted inequalities in our medical system. Patients are often coming in with significant mistrust of providers, of the healthcare system in general, and often of the VA, because many of our veterans of color have experienced significant race-based trauma during their military service. And even coming to the VA is very triggering for them due to our affiliation with the government and the military. I also think it's important to openly disclose appropriately to model that environment of openness, right? That it's not only okay to talk about these important issues of race, but it's important to the care. I will say that with any self-disclosure, of course, it's important to monitor our disclosures and keep our care very patient-focused. Especially if you identify as being a provider of color yourself, right? Race-based stress and trauma impacts us as well and can sometimes be triggering to our own experiences. So just being aware of, you know, the appropriateness of those disclosures. And this is where I think consultation with your fellow staff members is very important.
Right, so we are very lucky to continue with that kind of consultation stance, and it is, I think it's also very powerful just with the topic in and of itself, that for providers, many people have experienced some of those things. I think as was noted in the chat earlier, one of the participants noted that even providers had noticed some of the things that veterans were saying about them and how that also may impact their interactions with their veteran population. Now, one of the things we talk about facilitators of color, but I think one of the big questions that many people have is that for white providers, do we have any recommendations for ways that they can facilitate race-based stress and trauma groups? Because we also know that there's an underrepresentation of psychologists of color overall, yet the patient population would likely benefit from the intervention. So Sam, do you have any thoughts about that, or how we can move to expand the offering of this?
Thank you, Veronica. Yeah, I will start by saying it's tricky. It's not a straightforward, you know, can we do this and do it well? I will say that at least in San Francisco, Dr. Hubbard and I, as we've gone through many cycles of this with other providers in our system, we have only had psychologists of color, actually psychologists and social workers of color, providing this together. And we have encountered that question as other providers in our system who are white have asked, you know, how can I be involved? Should I be involved? And we actually would like that to be an evolutionary step of the way this group is provided, because we would like to be able to open up dimensions of the discussion over many sessions to include white people as allies. I think that the thing that we benefited though from just organically with having providers of color is that sense of connectedness and safety in the room when it comes to starting out a group like this for the first time in the medical center, and in many places in the VA for the first time in your VA. And so I think as a good start, it can be a helpful thing to have providers of color. However, of course, the challenges are that maybe you don't have a lot of providers of color, or they're not available. Or you don't necessarily want to make all the providers of color be the ones who are already doing this work and continue to do this work for the system. So it opens up other questions. And I know, Maurice, you've been able to do a mixed race group in the past. And so I think it's a both and, it's not an either or when it comes to who are the providers in this group and its timing and sequence of when to do it. But I think those are all great questions to kind of hash out as you continue to try to set up these groups and do these groups. I'll pause there.
So Maurice, would you like to share a little bit more about what it was like for you with doing a mixed race group?
Yes, I'd be happy to. So I've run actually a couple of those groups. The original group actually in Austin was a mixed race group as far as facilitators go, with Marie and Dwayne Luster and myself, Marie Carlson. And it actually went well. I think, you know, there's some things that if you aren't a person of color, or even sometimes if you are a person of color, I think Dr. Trujillo and Dr. Zuniga, who talked last week, talked a bit about this a little bit too, maybe perceived as, being white or not a person of color. I think you have to be prepared for some of the additional questions. And that's some of the things I've seen in doing that. I think after that initial discomfort, and kind of checking you out to kind of maybe understand a bit more why someone who's not of color might be interested in this, conducting this group. It actually was very meaningful for many veterans. Some of the feedback was it was meaningful to know that someone who wasn't a person of color cared. And so I do think there can be a place for that, but I think you have to be very well prepared. For example, some of the first exercises that we do, I actually encourage in some of the consultation that we that people are practicing those things before they even consider going into it. So they're sitting down with colleagues, if they got a co-facilitator, and practicing that they're talking to maybe trusted colleagues about these questions and really educating themselves prior to being able to dive in and do the group. So really doing a lot of prep work. And then being ready for some pretty difficult questions to be thrown their way, such as, why are you here? What authority are you working under? Are you really here to help us? And I think being ready to answer some of those questions that may be hard to hear, but I think it's important to be prepared and be able to handle them well so you can help build that trust with those veterans.
So thank you, because I think, again, I don't think I can tout enough the value of consultation in that way, because you wouldn't be alone in that. And I think that concept of practicing, even going back to what Clarice was discussing about self-disclosure and maintaining boundaries and being able to, in many ways, process some of these things yourself, whether you are a psychologist who is white and has not thought about these things or even felt this type of discrimination, or as a psychologist of color and processing these, not having these things come up for the first time in session for you as well, but making sure that you're processed and ready to discuss these things in that group setting. Another thing that often pops up too is intersectionality. So we may be pressing these groups forward and thinking about race and ethnicity, but what about those intersections? So Juliette, how do you address intersectionality within the group setting?
I think that's a really important question. I think there are some of the main forms of intersectionality I think that arise in the group are race and gender, race and age, and perhaps or generational status, and perhaps race and sexual orientation. I primarily, in the groups that I've run, I've primarily looked at or sort of dealt with issues of race and gender. So I'll kind of use that as an example of how we can talk about it. So one thing that comes up in the groups, and to sort of set the scene within the outlines that we generally use in the manual that we use for these groups, there's no explicit discussion of intersectionality, but it's something that always comes up. And so in my groups, I do mixed gender groups. And so we have male veterans and female veterans. And one way that this can come up, this is just an example, is talking about sort of the oppression hierarchy in a way, or this sense that, you know, maybe one gender group has it worse than another gender group. So like, you know, and the way that we usually address this, or the way that I address this, is really talking about, you know, it's not a hierarchy, and understanding that these intersections lead to people having different experiences of discrimination and oppression. So for Black men often have to deal with this issue of being perceived as dangerous or being perceived as criminal, and how that impacts interactions with the police and risk for things like police violence, or risk for being pulled over, or risk for being questioned. For Black women, you know, we can talk, for example, about the hypersexuality, the perceptions of hypersexuality of Black women, and how that impacts, you know, risk for sexual assault, and how Black women are treated after they are sexually assaulted, and victim blaming and things like that. So we see that those two things are different. Not one is not worse than the other, but sometimes people in groups can feel like, can bring up sort of, well, we have it worse, or we have it worse. Same thing happens with sort of generational status. You know, people who are from older generations may say, you know, well, we had it way worse. There was a lot more overt racism, and helping people to understand that these experiences are different, but that it's not on a hierarchy. The one other thing that can come up is understanding how these intersections of gender and race, for example, can impact how people respond to racism, how people react to racism. So women and men, we know in our society, are socialized very differently. So men may be socialized to perhaps be more sort of maybe action-oriented or outspoken, whereas women may be socialized to be a bit more sort of demure or meek or passive. And so that's going to impact how people respond to racism. And so we also talk a lot about, you know, how do people's experiences and their upbringing and their socialization impact their thoughts and their feelings and their behaviors when experiencing racial stress and trauma. And I think that's also a really important point to push forward in the groups. And I know there's a lot of stuff I'm missing, but those are just some examples of how intersectionality can come up.
No, I think that's fantastic, because I think it does touch on many of the different dynamics that I don't think just initially people are going to think of coming up in the group dynamic and setting. And so when you're preparing for this, I think you need to be very much aware that those things are going to be present. And as we talked about before, ensuring that you have a safe space, right? Because bias isn't only based on ethnicity or race. And so I think that's another question to really move forward with is, do you address bias, discrimination, and prejudice within the group setting? So Keisha, how do you address that with your groups?
We definitely do address that, and we have a full session that focuses on implicit bias, talking about discrimination and prejudice. I mean, we fully discussed like the academic definitions, like how that is defined, you know, within research literature, but then we definitely get into, okay, what does this feel like? What is the experience? So we have interactions about that. We include watching videos as well and having discussions around implicit bias, which often is tied into empowerment, because we start to recognize what are our own biases, right? I mean, even though it might be a set of veterans of color, you know, there's still intergroup versus intragroup kind of issues, and talking about discrimination within one's own community, as well as within the military, just the experiences they had within their own racial group. So that becomes very important, because I think sometimes there might be the assumption that coming into a veteran of color group that everyone will kind of be on this same page, but we recognize that there's of course heterogeneity within groups. So that's often a very important topic that's not only limited to just that one session, but we found is interwoven throughout much of the group, which is the challenge too, because, you know, there's racial discrimination within structural systems, but then we have prejudice within one's own group. So it's having to, how do you navigate on all of these fronts? So those are very complex conversations that we often have with veterans.
I think it's very interesting, and important that you mentioned systems, because we are in what you would define as probably multiple systems, right? Here in the VA, we're dealing with the government, and we're also dealing with healthcare. And I think one of the big questions is really, do many of our veterans describe experiencing discrimination in the healthcare, and maybe even specifically the mental health care setting? And if so, how are you addressing that? Because we are the system. So Sam, how would you go about thinking about that?
That's certainly one of the biggest challenges I think we do work on. And I happen to also work in a substance use and PTSD program, and avoidance is a common thread when it comes to stress and trauma. You want to minimize or reduce the stimulation of the stress and trauma and its triggers, of course, and that's a natural response. And you also don't want to start to encircle your life in such a way that's so narrow that you're not able to live it in the way that you hope to. And so we really try to walk that balance. And this is where the empowerment dimension is something that we wanted to introduce here in San Francisco, and I know is also embedded in the work overall, which is to say that there is a very valuable dimension of this work that really is about witnessing and experiencing some of the actual despair and difficulty of confronting racism in our work, and at the same time, in different phases of the work, you can start to shift at times to thinking about how do you want to live your life despite or in the face of these types of challenges. We all know and recognize, and actually as we do these groups, we know these things are very real and also bring us down. And at the same time, people wouldn't be coming to the VA for treatment and or groups if at some level they didn't want to experience more in their lives. If at some level they didn't want to have more joy, more peace, more contentment. And so we try to circle back to those things as well, that if you would like those things, and usually the answer is yes at some point, may not be now, but as you try to pursue them, how can the group help you? How can the group be a support to you? How can we come up together with ideas that will help you to do that? So I think that it's a tricky thing to not sort of see avoidance as a natural response, but also that in the end, we're hoping for more contentment, joy, peace, relationship, enjoyment, all of the good things that we're after as well.
I think that leads to another, I think that moves us forward in another sphere of really, in the midst of talking about things that are so heavy, especially in light of everything that's not only going on right now, but what people have experienced throughout a lifetime. Juliette, how do we move towards hope and empowerment in today's society? How do you take your group in that direction?
Yeah, I think that's really the ultimate question, because I think that it's very, that sort of feeling, those feelings of hopelessness really pull us towards them, and it's easy to get lost in that, and also very understandable. I really like the way that French and colleagues put it. So they just had a paper come out in the Counseling Psychologist about radical healing for people of color. And they really talk about this dialectic of sort of having this awareness and this understanding of the interlocking systems of oppression, while at the same time having this sort of vision for what a world without oppression can look like, or what the future might look like. They call it envisioning justice and liberation. So a lot of it is about being in that dialectic space, and being able to see that, yes, we see the oppression, we understand where the hopelessness comes from, while also being able to envision a different kind of future. Because if we can't envision a different kind of future, then we do get stuck in the hopelessness. And so a lot of this in the group centers around the empowerment piece, and that involves, the things I think that really speak to this hope are helping group members to figure out what their personal work is, So how can you contribute to moving forward towards this new vision of the world? And that may be things like, and understanding sort of what your lane is. What does that look like? It can vary it varies from person to person. For some people, it's about taking care of themselves. And as being a Black person or a person of color, and making sure that they're able to get out and experience joy each day and take a moment for rest and raise their families. For others, it may be sort of broader societal activism, you know, so it may be things like attending a protest or organizing in the community, or, you know, what we're doing in running these groups, that may be our personal work as clinicians. And so helping people to figure out, what can I do to feel like I'm contributing to moving towards this potential future where we dismantle oppression, essentially. And it feels like a dream, but I think it's important for us to know, what are we doing to work towards that? And it can help us feel like we're contributing to that. And I think that that can give us a sense of hope and a sense of doing the work. So that's a lot of what we focus on in the groups to help people. We do it's sort of a community engagement or cultural engagement exercise, where we have people find something that's going to help them feel engaged with their community and feel proud of their community and their culture and feel like they're contributing.
Does anybody have any examples of those engagement activities? I know that a number of the groups have those. Does anybody have an example of one that they'd like to share? Juliette, I'm going to pick on you since you brought them up in helping with empowerment. Can you think of one that was just striking to you that someone brought up and was able to actually implement?
Well, I guess one thing that I remember is one participant I worked with who, one group member I worked with who was being trained in a particular profession, and wanted to use that training and wanted to use their professional skills to create community spaces where Black women and girls could come for support and mental health treatment and things like that. And so it's kind of similar to something that I relate to as well, but that was sort of her personal work of how she felt like she was giving back to the community, and really focusing specifically on her community of Black women and girls. So that's one example I can think of. I know other examples that have come up are in one of the papers that Maurice is an author on, Dr. Endsley is an author on, but things like, I remember, oh yeah, this is an example in the paper of somebody who was upset who was participating in a veterans parade and was upset that there was a Confederate flag that was allowed into the parade. And so stood up for that belief and, you know, told the committee or whoever that they didn't agree with that and they didn't want to participate if that flag was going to be allowed, things like that. So things that it may be sort of a long-term thing, or it may be sort of just communicating in a way that feels effective for the person, that this is not okay with me and I don't support this. So I'd say those are a couple examples. I think Keisha do you have another example?
I was just going to talk about, actually within the group, we also have cultural sharing, where we have veterans bring in artifacts that are meaningful to them, as well as we also as providers share at times too. And we've had such interesting things come in, whether it's something that was passed down intergenerationally. Some people brought in medals that they'd received, you know, for their works in the community. So also just highlighting, again, aspects of themselves that we might not have known about if we didn't have that activity. So that one is internal versus within the community. But part of what the minority stress booster group that I ran was Dr. Wang. Some of what was done just locally, they started building, you know, list of like businesses and those kind of things that were owned by people of color that, you know, that they could support, as well as those within the group themselves who have businesses, you know, actually providing support, you know, outside of groups. So it's wonderful to just see that level of connection, that even after completing the group, you know, there are those who may remain connected.
So I think that leads us to another question that I'm going to pose to the panel, but we're also actually going to take some of the questions that we have in the chat box, as well as some questions from the larger group. So if you have a question for us, please make sure that you entered in the Q&A section. And we are actually, my handy team behind the scenes, as well as myself, we are working our way through those and hopefully answering some of them, as well as we're going to try to answer a few of those live within the next 20 minutes or so. So Clarice, to kind of bring us all together, I think one of the things that many people are wondering about is, for this type of intervention, what would be your expected outcome? So what is the data showing? What are we looking at? What are we actually seeing as a result of this?
Yeah, well, our multi-site outcomes project is still currently underway, so we don't have official data yet. I can talk a little bit about the different types of measures that we're including and looking at. So we're including a number of different brief symptom measures, as well as measures of overall well-being and resilience, because as we've discussed, that is an important active component or active ingredient in this group. And so with that, I would say that, we do expect an increase in overall perceived quality of life and resilience measures. And I think it's important to note that what we expect is a little bit less clear when it comes to symptom measures, right? Because of what we have been talking about. Racism is not a mental health problem, right? We're not necessarily drawing from a mental health population. And because of this unique and different nature of race-based stress, right, symptoms are often not pathological and may be, in fact, very adaptive for these individuals in many cases, as opposed to pathological or maladaptive. I think what we're going to see on these symptom measures is a lot less clear.
So thank you. And panel, just bear with me. I'm going to bring you all some questions from the group. So here's the first one. I think I'm going to direct this one to Maurice. So the first question is, how is race-based trauma separated from other risk factors which are correlated with race, such as education, income, healthcare access, dietary adequacy, and underemployment?
Absolutely. Yeah, I would definitely identify those as more kind of systemic risk factors. So they likely create higher risk factors for someone to have a direct, individual experiences that where they may experience a race-based stress or a race-based trauma, right? So those are definitely some risk factors that kind of create the opportunity for that to happen to someone. I would focus more on kind of these race-based stressors as being those direct lived experiences that people do have with those systems, for example, that you've kind of identified in that question. And so that's, I guess, the best way I can think of how to differentiate between those two, is that one is just a set of the risk factors, and then what we're looking more at with the race-based stressors is that how does that person experience those things? So what are the individual interactions that they have? And oftentimes those are the places where we start to see the stressors show up and impact the individual. Because of those systemic inequities, they have to show up somehow in affecting the individual person's interactions.
Thank you. So the next question for the group, and I think we touched upon this because we talked about intersectionality and bias within the groups, but I think specifically people are wanting to know, has there been any within group discrimination in your group, and how has that been addressed? Keisha, I see you talking, but
Thank you. Wasn't unmuted. So the question is, actually within the group, has it occurred, or do we address it?
Yes, within the group setting.
That's a good question. I was thinking more so in the broader context. So I'm thinking back to my group experiences, and I think we have. I think we've had some prejudice in forms of like colorism. We've had that in some of the groups, just talking about the different experiences as people have talked about their military experiences versus others. They brought that within the group. I think, yes, there was a distinct disagreement with probably 3 to 4 veterans about that, just in terms of, you know, the thoughts of how colorism impacts military experience. And then it was also brought up that within the group itself, that they felt as though that there were different perceptions of those with lighter hue versus darker hue. And part of how we also brought that in is just talking about historical and societal context of colorism, how it started. We talk about slavery, we talk about integration and how, you know, lighter individuals in not just America, but in many societies in the Caribbean and Africa and Asia, other places, you know, how more distinction is given to lighter complexion. So we talk about it in that context. We also talk about post-traumatic slave syndrome as well as internalized oppression and how that manifests individually as well as how it is projected within the in-group.
Excellent. And I think as well, for those of you, when we talk about creating a safe space, I think one of the important things is that during the very first session, the rules for the group are very much laid out. And so people are asked to be mindful and respectful of others and others' feelings, and so there is a precedent for if you feel as though someone is doing something that is discriminatory or demonstrating bias or that could be harmful to someone else in the group, within those kind of that setting of the group rules and in seeking a safe space in that way very early on, I think you set yourself up to be able to address that later on in the group if it does occur. So here's our next question. Do you have any suggestions for discerning between actual race-based threat and exaggerated beliefs? So for example, those that should be targeted with CBT approaches. I find this especially difficult when I may come from a different racial background with my clients. Does anybody have any thoughts about that question?
Yeah, I can speak to this one a little bit. I do think that it's tricky, especially when you're working with someone who has, you know, let's say for very severe combat-related PTSD symptoms, as well as race-based stress and trauma experiences. And so with this, I think it's especially important to keep the conversation about avoidance and these discussions of perceived versus actual threat very, very patient-focused. Right? We are really not here to be the arbiters of truth, right? Because our reality, our experiential reality may be very, very different than that of our patients. So, and patients, in my experience, patients are very aware of this distinction, where it's more PTSD, combat PTSD related hypervigilance and avoidance versus an actual adaptive avoidance or hypervigilance due to race-based stress. So my approach personally has always been to just be very clear about these different types of avoidance and really highlight, you know, in what ways is avoidance actually protective for you, and in what ways has avoidance been a barrier to you achieving things that you want to achieve and preventing you from values-based action. And I don't know if other folks wanted to jump in on this one.
Because I have a follow-up question to that, because I like that you talked about kind of avoidance, because someone else asked how you balance talking about avoidance as a maladaptive thing that can prolong anxiety or trauma symptoms versus an adaptive thing that is a reaction to real danger in our society. So anybody want to add to that?
Sure, I can see if I can answer that one. So the question is asking specifically, how do we, you know, determine essentially if avoidance, or in some ways I try to be careful about the word hypervigilance in the case of race-based stressors, because unfortunately it is something that's within our environment, right? So I think part of that is exploring. I think initially you really want to explore, you know, what is behind that. What is it about that person's experience and maybe leading them to that conclusion? Unfortunately, in the case with the way that racism is sort of within the ether of our country, it's oftentimes really difficult to really say that, you know, it is always safe, because we never quite know when those things may happen. never quite know when someone's going to be stopped, or, you know, and a microaggression leads to more violent incidents. Unfortunately, we see this happen all the time. And then on top of that, our veterans are also blasted with the news of this, so they constantly hear about it all the time. And so I think it's really, one of the things that I prefer to do in that case would be to just explore with them what it's like, and in what ways are the, you know, is the avoidance, kind of as Dr. Wang mentioned, you know, is the avoidance kind of helpful for them, and kind of how is it protective for them? And there's being really careful about my own assumptions, right? If I feel like it's limiting their social support, is that really a value of theirs? And then trying to explore that and find, maybe, I think if both you and the veteran are on the same page about wanting to change something related to that after that exploration time, I think that's where you can maybe enter into some problem solving, or enter in, you know, some ways to kind of talk through how can we handle that or plan, like using some of the other tools that we use in group. We could do that. There's some the racism recovery plan, those types of things where you can help the person engage in some planning to kind of better address their sense of safety with those situations. So hopefully that answered the question.
Yeah, I think that, again, I think we talk a lot about kind of collaboration and meeting the veteran where they are, and really looking at kind of their own individual reaction to situations, and being very mindful of that. And I think it just goes back to what Clarice said, you know, that in many ways this is coping, right? That because someone has had to deal with racism, that is not, that is a part of what they're dealing with in society, and how are they coping with that. So one of the things I wanted to get back to, Juliette, was there have been a number of questions about micro aggressions. How, you know, we talked about some discrimination within the group. How do you deal with some of those microaggressions within the group setting?
Yeah, I've also noticed some people asking about the definition of microaggressions, and I've definitely had pushback from group members who say, well, these aren't micro, this is just racism. Mm-hmm. And I totally agree with that. And I also want to clarify how these terms are used. So microaggression is used to refer to interpersonal experiences of racism, whereas macroaggression is usually used to refer to systemic acts and policies, or racist acts and policies. So just wanted to clear that up. But in terms of dealing with microaggressions in session, so this is something that was a learning curve for me, because what happens is that there definitely microaggressions can come up in groups. And so, for example, one thing that I notice in my groups, because I'm in Boston, we have a very ethnically diverse Black population in Boston. And so we have people from all different countries who've immigrated to the US, or who identify as Black, Hispanic, or something like that. And that can bring up some tension in the groups, because there's often sort of this idea of, I guess you can call it ethnic racism, where there's a way that that Black people, for example, maybe have internalized different sorts of racist ideas or beliefs about people from other countries who are also Black. And so when people sort of immigrate to the US, they can have some experience of that. And so it can cause some tension between different sort of Black people with different ethnic backgrounds. And so that has come up in the groups. And how I tend to address it is that, like you said, Veronica, at the beginning of the groups, we go through the group guidelines. And we explicitly say, if a microaggression happens in the group, we are going to call that out, more or less. We're going to label it. We're going to name that that's a microaggression, and then we're going to discuss it, and we're going to try and talk about where this comes from, why we may have these certain beliefs. It may be based on people's experiences. A lot of it is internalized, maybe internalized racism. And it all really goes back to the root, which is white supremacy. And so we're able to have some of these more dynamic conversations about the dynamics of white supremacy and racism, and how they sort of enter into our system, and how they affect how we view other people who are within the same sort of racial groups as us. And I've only led groups with Black or African-American participants, so I can't necessarily speak to some sort of other group dynamics where maybe you have a Black participant and maybe a participant from a totally different racial background. But I can speak to sort of some of these race, ethnicity intersections. One other thing I was going to say is that oftentimes a microaggression may occur, and as group leaders, we may not, especially when we're first starting out, we may not always know how to address it or what to say, and we want to maintain rapport with everyone in the group. So it's tricky, but I think that an important thing to remember is that if you don't address it in the moment, it can have consequences, but you can always come back in the next session and talk about it. You know, so if you don't know how to address it or what to say, talk with your co-facilitator after the group, supervisor, if you have a supervisor, figure out how to address it and address it in the next group. I think you always need to address it. I think it can be very harmful for the group dynamic and for the group members not to address a microaggression that occurs in group. And I don't know if others on the panel have other ways that they've dealt with microaggressions that have been effective for them.
I would just echo what you're saying, Juliette, about boundaries within a group, because I think we also want to remember that these are therapy groups. These are, or at least they are, groups that happen in a therapeutic setting. And as experts in group dynamics, we also don't want to leave our skills for group dynamics at the door. And maintaining safe boundaries for discussion and understanding consequences of what happens in the group is important. And in our experience in San Francisco, although there are multiple factors that went into one experience of asking a group member to really invite him to really look at his statements in the group, they were more age related, in fact, in this particular instance, because he saw that a younger veteran's perspectives weren't as valuable, or that the person wasn't thinking about kind of the older person's perspective. And I think he was probably feeling invalidated as well. But his way of approaching it became quite angry, and not just angry, but also crossed the line to kind of threatening. And so I think those are very tricky, because I think we are in territory that needs to allow for a lot of affect. But at the same time, we do have to respect specific boundaries, especially when it comes to each person being able to show up and being able to show up as their whole selves, and be able to be safe in that space to talk about some of those things. So I think we do have to really pay attention to some boundaries around that as well. But it's important, as you said, Juliette, to make sure you're addressing them over time.
So thank you very much, Sam. And I just want to point out, I wanted to make sure that we acknowledge all of our colleagues. We have chat as well as Q&A, but I know that Babette has some information about microaggressions that I think is very valuable for people. That is in the chat if you want to have more specific definitions. And so I think that can be highly useful to people to get a clearer understanding of what microaggressions are. So I'm just gonna point you back in that direction. We also had a question in regards to assessment. So regarding assessment, when do you think it is assessment for a Black or Indigenous person of color to, 1, avoid because there may be actual heightened threat, or 2, be more vigilant than their peers given their experience, 3, assert blame to others? For example, the assimilation item on the CAPS 5 and the DSM-5 criteria. So Maurice, I'm going to give you that question. So.
Thanks. I want to make sure I have a good understanding of the question, actually in particular. So I'm not sure if the question is asking how can we better improve it to address those 3 items listed, or yeah. So I'm not 100% sure necessarily what that question's.
So, and I guess for us, I think within this question that they're really trying to get at assessing for these 3 things to see how you distinguish. And again, this is my interpretation. So if you wrote this question, please feel free to clarify so that we can get you the exact answer. But that's what I'm gathering. And the panel can disagree or give some more input. But Maurice, that's what I'm getting from this.
Yeah, so I guess I'll take it from the stance of, you know, what are some ways in which we might be mindful of those things. I think, you know, there's other measures like the unrest measure by Monica Williams, which actually takes a CAP style look at and trying to improve the classification of racial trauma, for example. That's another, you know, interview that could be a little bit better to make sure that we're tapping into those concerns. And I would say, you know, oftentimes folks may not be comfortable discussing these traumas. I will say that in group, we've had a numerous first-time disclosures in our groups. And so I think that's why that trust and is so important. And I think as an assessor, we have to be able to signal and show people that we are trustworthy for that, because I just noticed that that's really important so that we can get the most accurate assessment that we can. So I think by starting to ask very directly about these experiences is one of the best ways to show that you're interested in your care. And I think that that's an important thing. Oftentimes those measures don't tap directly into the specifics of those types of experiences because unfortunately, they weren't developed to tackle those types of concerns regarding race-based stressors. So oftentimes it's important to use some of the things that Dr. Hubbard mentioned earlier in that conversation, when you're doing that assessment, to ask about experiences with racism, discrimination, or do you think that race was a part of the trauma potentially? I think there's ways you can ask around that so that you can get a better and more accurate picture. And also I think, just by making sure, like Dr. Robinson mentioned earlier, making sure that's a part of your initial assessment will give you a better picture. And even if they don't disclose it, maybe the first time, maybe you're setting it up that, hey, clearly this person does care. Maybe once they feel more comfortable, they will be more open to disclosing and talking about, and you can get more information. So I'm hopefully that's answering the question. There's a few other measures, I think, that depending on what your role is and how much time you have, there's Dr. Carter has a measure, the race-based stress trauma symptom scale. I hope I'm saying it right. And then there's also another one, the trauma symptoms of discrimination scale by Dr. Monica Williams as well. That's a little more clinically wieldy. So I think that's one way to kind of prove assessment. So correct me, feel free to jump in, folks, if you feel like I'm missing a piece of that question. Hopefully I tackled it.
So first of all, we're gonna have one last question that I'm gonna give to Dr. Ross, but we're going to wrap this up because we have 2 points to make. One is just our last question, and then I know that we wanna make sure everybody knows how to get their continuing education. Those who are available will actually stay on the Zoom for a little bit if you have some burning questions, and we're gonna try to save some of those questions as well. But the last question that I wanted to make sure I got out there was, so Keisha, many people are looking at how do you start one of these groups?
So if you have an interest in starting a group, you can contact myself or Dr. Endsley. We will post in either the chat box or we'll have Tiffany send it later on more so an email or listserv. You will contact us. Through the Innovation Spread Grant, we have consultation groups, which are via Skype, and where we provide training for the protocol and continued consultation before, during, and after group. So if you have interest, you can use that information and just contact us and we will get back with you. And all of my wonderful esteemed colleagues that are on the panel right now are part of the consultation group. So a lot of this great specialty training.
And Maurice, you wanted to say something really quick before we...
Yes, yeah. So I also wanted to make sure we gave appropriate credit to the folks who worked really hard on the 8-session model, Doctors Lindy Schauheim and Darnell Motley. They have been instrumental in this, and it's actually the outline that we started using for this consultation. And subsequently, I want to thank also any postdocs, trainees. They have been so integral to keeping this going and helping us to taking their time to develop. So Jamie Rislin and VA San Antonio, so I just want to thank them too for their contributions to this project.
Thank you. And I just want to say thank you to the panel. Again, it is such a pleasure to work with you all, and just the wonderful work that you've done. And kudos to actually all of the people across the VA who are implementing these groups. It is just a wonderful thing to be on a consultation call. We had 15 people on our last consultation call alone, and just the good work that they're doing. So thank you to everyone out there. And so Tiffany, we never have enough time, so but I'm going to give it back to you.
Okay, well, thank you so much for such an excellent presentation. I'm glad you'll stay on to continue taking some questions, and I'll continue recording the webinar. So for people who need to take off, this will still be recorded, so you won't miss a thing. But just want to wrap up with some housekeeping as far as how to claim CE credit. So if you're interested in continuing education credit, you'll need to complete the program evaluation, and I'm putting that in the chat box. It will also be, as you close out of Zoom, it should automatically direct you to the SurveyMonkey link. But again, I'll put that into the chat box here in a moment. And for members of Division 18 and AVAPAL, of course, this is a membership benefit to you, so you won't have to pay CE fee for the credit. If you're not a member of these organizations, but you're still interested in claiming CE, then you can pay the $15 fee through our PayPal account. And I'll put a link to the PayPal there too. And then I'll also send a follow-up email within another day, just to remind people of all of these instructions. And then finally, just stay tuned because we're going to continue the conversation. At the end of August, we'll be having a conversation about establishing and maintaining diversity and inclusion committees. So stay tuned for more material or more advertisements about that upcoming webinar. So I'll put those links in the chat box, but I'm gonna go ahead and turn it back over to Dr. Shead and the panelists to continue answering questions. Thank you everyone for attending.
And thank you to those who have to get off. Again, the information, if you want to ask more questions, if you want to join consultation, please feel free to follow up. I know we had another question, and it was related, go back a little bit. I know we had one that was actually related to pushback for starting groups. Since we just talked a little bit about starting groups, how do you deal with pushback when it comes to actually getting a group started in your facility?
I can start off with that one. I know I have some excellent colleagues who also have some awesome comments that I'll probably follow up. But I think one of the things is that I've learned in kind of discussing, pushback or maybe why we want to do a group like this, like why is it important? I think first is to understand where is the leadership coming from. So, what are their concerns? What are the reasons why they're worried? Are they worried that this is going to turn into something that, folks are going to be upset about, that this is offered and they're not, able to take part in it, based upon race, that comes up as a concern. Are they concerned about, like how clinically relevant this group is? Is it an EVP? I think there's depending on your sites and depending on how I think leadership and supervisors, mentors, how they focus and what they oftentimes are kind of the important things for them. I think it's important to have a conversation about, what are your concerns, or what are the things that would need to be in place for this, to have this group. Is it, staff clinician time? And I think there's ways then we can sort of develop and problem solve. So that's actually one of the things we tackle, when we first started the groups for consultation, we tried to start tackling that and offer resources. Some of the things that I do is, at the time when I was offering to come and do a training or do a talk or do something like that, or, help folks develop their own talk to present to leadership or present as like an education opportunity for staff that helps to kind of drive some of the understanding and wishes. And sometimes that can help to just get leadership a little bit more on board when they kind of maybe understand the problem a bit better. It's not something that I don't think we talk a lot about. And so oftentimes they may not have a great understanding of, the importance. I imagine maybe some of that has changed, or maybe because of the politically charged nature of things right now. they may be a little bit wary of a group like this. But I think we can talk about that. And then you can share details. We've developed this across multiple VAs at this point. We have resources, you know, within the consultation. We'll share that. That's something you can discuss with leadership. Oftentimes I'm open to talking to anybody that wants to, you know, learn more about these groups, learn about this topic. And I'm happy to share information or even have a direct conversation with them.
I think one thing that I would add to that, to what Maurice said, is I think being able to, I think one of the things that really helped at our facility was to kind of get that buy-in through provider experiences. So one of the things that happened in a couple of our clinics is that providers were kind of talking about this, like things were coming up clinically. And so it kind of caused this momentum where there's this sense of, you know, providers feeling like this is coming up and not feeling like they had the tools really to know adequately how to address that. And so I think that really helped with buy-in and for us in terms of getting it started at our facility. And I'll also say I was a fellow at the time and Sam was my supervisor. So that also I think helped, you know, too. I think having that support of others who really were kind of getting a sense of what we were trying to do and really wanted to provide a very much needed resource.
So thank you all. So the next question that I have is on how do you address race-related stuck points in PTSD, ESTs such as CPT. For example, the idea that someone would have a thought that all white people are racist, all police abuse their power. The person asking this question finds this challenging because there's often some truth to these statements and they do not want to invalidate their experience. So how have you addressed that before?
I don't mind taking this because this comes up often in my groups. For me, my goal isn't to readily challenge those beliefs at the outset of group because one, it is about building rapport. It is about respecting their unique experience. And so I don't want to be invalidating. However, the great thing about this module is that it includes different video clips and things like that. And so when we talk about empowerment and moving the moment forward, taking this from a moment to a movement, we look at historical movements that have been successful. You know, we talk about the inclusion of allies. And so there is usually discussion around how there are spaces that people of color may never make it into due to systematic oppression and racism. And so we do need to not only challenge, but support those allies who are willing to raise those questions in those spaces. And so because it does also require this unison of people of color and allies, that at least creates the gray area for addressing the all whites or this or all cops or that. And so when we have those examples, like we use Jane Elliott's Brown Eye, Blue Eye study as one of our videos that we watch, being able to see how a white female school teacher was able to give this very real life lesson to a classroom of all white children and how that had everlasting effects kind of, you know, creates the room for our vets to be able to see that, okay, maybe not all, right? And so then that sparks the conversation and starting to create some of the gray.
And I think adding to that, I think that's such a wonderful approach, Marva, Dr. Robinson. I always want to say doctor. Anyway, so, but I think another thing that you can maybe add to that is, you know, at the end of the day, white people, and I don't mean all white people, I just mean in general that the systemic racism was really created and instituted by white people, by white society. And so at the end of the day, I think that white people are the only ones who can really dismantle it. I think that if Black and Indigenous people and people of color could dismantle racism, it would be gone. And so I think that that could potentially be another way to talk about that, is that, you know, piggybacking on that idea that we need allies. Because at the end of the day, we as people of color are not going to be able to end racism. We need white people really to do that. And we can focus on our communities and communities of color and how we can support each other and help each other to heal from these experiences.
Yeah, I would add to that too. I think it's important to actually think about the definitions here, especially in this, are we talking about, when we talk about, and this is something we also discussed in the group, like what are the actual definitions? What are the barriers to discussing race? And I think this is actually one that pops up quite often. What do we mean when we say everyone is racist, or all white people are racist? So that term racist, what does that mean to them? Are they actually talking about prejudice? Are they talking? So I think part of that is when you're exploring and you're going to tackle something like that, we really make sure we're on the same page as far as the definition of that. So I think it's important to explore that because some of those things might be more true. Pretty much all of us are prejudiced. We all have our prejudices. Those are things that we're taught and messaged to from society. So we don't want to ignore that piece of it. And I think that's where we may run into a problem when trying to process or challenge those types of beliefs, is we're not working on the same definition. We may be doing more harm than good. So I think part of that is why it's so important that when someone makes that statement, to continue to make sure you explore and understand that a bit more before I think challenging or I would be very careful about challenging in this case without having a really good understanding, and the veteran definitely being on board and wanting to change that perspective, because I think there's a lot of risk for doing harm, especially when we know that walking around with some of those beliefs can be even more harmful. Beliefs that go against that can be harmful, or make it more dangerous for them. So I think it's a tough one. I think it's a really hard one, and I think that's where some of our not that this can't be done using CPT, of course. I think this work could be done, but I think we have to make sure that it's incorporated in the training and that we're doing it well. And that's one thing that I hope that we continue to improve upon. And this group is designed to be set up to help, those types of traditional trauma treatments tackle these issues that weren't really a part of the trauma treatments and their development themselves. And so that's why we're here. So I think that using some of the tools that we use in group may be another way to actually tackle that, as Dr. Robinson has presented.
And just to tack on the end, because the same question also asks about in vivo and when it may be safe for patients of color or not. I think, like I stated in the presentation piece, for me, the most powerful piece of this protocol is the empowerment. And I think when you first have someone who has been able to be empowered, increase self-esteem, aware of their rights, there's one exercise where we do a personal bill of rights. I have literally seen the expression of vets change to one of more confidence when we go through that exercise. I think when you can get vets in that position, then testing the waters about their comfort level of more of the in vivo exercises, that can kind of help guide your indication as to when that's appropriate.
Another question that someone asked earlier is, are there environments that have more race-based stress than others, like the U.S. military versus USVA, or for student veterans more than veterans at work? I think this is interesting because I'll let the panel take it, but I know what my thoughts are on it. But does anybody have thoughts on, are there settings that essentially could be more stressful than others?
I don't know if we have any hard data on that. I could be wrong. I know there was a study that came out a few years ago by Leslie Hausman and her colleagues that found that veterans reported experiencing just as much discrimination within the VA as they did in healthcare systems outside of the VA. So my answer to that question would be probably not. There probably isn't a big difference between settings in any systematic way. Just like people who are Black, who live in, in poor neighborhoods experience a lot of discrimination and racism, so too do people who, we see these, what am I trying to say? we see similar levels of racism and racial stress among people who maybe have higher levels of education who work in professional settings. So we see racism across all these different settings, no matter what somebody's other identities or backgrounds or, you know, may be. And so I would say probably we don't see any differences in any systematic way.
And I think it's important to consider as well, like intersectional issues. So, you know, when we're thinking about, like, I think the overall safety, right, it comes across differently when you consider intersectional identities. So the experience of an African-American man in the military and the VA is going to be different than an African-American woman or someone who identifies African-American LGBT, right? So I think it's important to also keep those things in mind when we're talking about the context and the situations. So I think it's incredibly complex. And I think everybody's going to have a different experience, and that's important to keep in mind.
One last bit that I'll add on to this is also, I think it's important for us as clinicians to remember in our practice that, you know, a lot of times when we talk about racism, and especially with regard to microaggressions, we define it based on the perception of the experiencer, right? So if the individual believes a remark or a look or a comment to be offensive, then it is just defined as such. And so again, I think it's important to kind of put the power of kind of assessing whether or not something is racist or offensive on the individual experiencing it.
So I do want to address as well that we will be sending out the references, links to how to get involved with, how to get access to a number of the resources, as well as if you're interested in holding the group or participating in consultation, there you can have, that will allow you to essentially access our SharePoint if you're kind of working through the protocol, where we have a vast number of resources that are very helpful, that have been used across numerous settings within groups in the past. So again, a great source of resources there. And like I said, I do believe we're working to get you all the resource list so that you can have access to everything that was discussed today in the presentation. I'm going to see if there are other questions that we did not address. Does anyone else have another question? Anybody on the team see something that I may have overlooked through the Q&A and chat sections?
I'll just add one response, which I think there was an earlier question about how do you talk about these things with clinicians and providers as well. And I think you're looking at it. I think that an event like this is designed to really help all of us, the panelists as well, and our attendees who are providers and clinicians, to open up these spaces, open up these discussions, and to bring it home to wherever you are somehow. But I think you do want to find people that you could start with, of course, that it might be very hard if you're in this place. And just to answer kind of the other question about, are some places harder than others? I think, yeah, at some level, there are places that are just harder to bring these things up with than others, some VAs and some cultures in some VAs. So I think you want to find a group, and maybe the national consultation calls, which we have been going on for some time, would be a place to start if you can't find places in your own VA. So I think talking to other providers is key, and getting people on board is key to being able to start this at your own VA. But this is an event that's designed to help with that.
I did want to follow up just on one of the questions. Someone asked, if you're an intern, how can you go about starting this group? We haven't had on the intern level. Usually interns, you can touch base with supervisors to see if the protocol is available within your VA, and you may be able to make that a part of your training experience. However, we do have our residents, postdocs who do some of the consultation training to start the group. So just if you're at a level of training, contact your supervisor or your director of clinical training to see how it could be something that might be incorporated into your training year.
I will also say there's another question about, is consultation open to all mental health disciplines? And yes, on my last consultation call, I believe I had 3 social workers who were within that call. So yes, we have been open to other providers. And I know that groups elsewhere have been co-facilitated by other mental health providers as well.
We've also had peer support specialists as well. Oh, sorry, Sam. But we've also had peer support specialists who play, I think, a unique and important role as well. So.
Yes, and that's just to piggyback on that, including in multiple disciplines is one way to increase your provider pool, so that you have as many providers over many cycles as you can and keep it sustainable.
Yeah, I would say that the original Austin group, if it weren't for having peer support specialists as a part of that group, I don't know if it would have gone as well as it did. So I think it's really important to think about our other colleagues too. So social work, psychology, peer support is a really great, if you can find someone who's a good fit, is another great resource to have within the group. And so I have the pleasure of working with a peer support specialist here at Hines, and it's amazing. So open that up, and I think there may be hard to find people, but if we open up beyond just psychology, it makes it a lot easier.
Well, all right. I think we have covered most of the information today, and any other questions. Thank you all so much for participating. Thank you all who held on for the extended portion of the presentation. Again, it was our pleasure. We really feel like this work is so important, and are grateful to have the platform to share the information about this work with you all today. So thank you all.
Thank
Bye.
you. Ending.
Thank you.